Before we officially start the webinar, may I just share a few house rules? May I please request everyone to be mindful of their microphones and camera. Please keep them turned off during the duration of the program for a seamless flow of our activity. Should you have questions for our speakers, kindly type them on the chat box or click the Q&A icon so we can entertain them towards the end of the program. Kindly indicate your name and your institution or country to whom you would like to address your question. Today, we have invited guests who will share with us relevant information on advancing nursing care in pediatric trauma. This program aims to enhance clinical decision-making for managing life-threatening childhood injuries while strengthening trauma-informed, family-centered nursing practices. It also promotes multidisciplinary collaboration and advanced nursing roles to drive injury prevention, quality improvement, and better outcomes across the entire continuum. So may I request all of you to please settle down as we start our webinar and introduce our lead for the GICS Nursing Working Group. So it's a privilege to introduce a globally recognized leader in nursing education and pediatric research. While she has held prestigious administrative positions, including serving as a former dean of the College of Nursing at CMC Vellore and editor-in-chief of the Indian Journal of Continuing Nursing Education. Currently, she serves as the lead and chair of the Nursing Working Group for the Global Initiative for Children's Surgery. Please join me in giving a warm welcome to Dr. Vinita Ravindran. You may now have the virtual floor, Prof. Vinita.
Thank you, Kay, for that introduction. I just have a few words of welcome to each one of you. It's a pleasure to invite each one of you for this webinar. We as a nursing working group, we meet at least twice, once in 2 or 3 months, and we think of topics and nursing care points that are relevant for children who undergo surgery. And our mission, I just want to share our mission with you. The GICS Nursing Working Group is committed to advancing safe, equitable, and high-quality pediatric surgical nursing care worldwide through compassion, advocacy, inclusivity, collaboration, and evidence-based practice. We strive to empower nurses, strengthen healthcare systems, and ensure that every child, regardless of geography, socioeconomic circumstances, or any available resources, receives the highest surgical care that can promote best possible outcomes. That's our mission, and towards that, we conduct webinars so that we can empower ourselves as nurses on different topics so that we can get the best out of these webinars and can give the best care to our children who are surgically ill. And therefore, I have the honor to invite all of you to this webinar, and special invitation to all our resource persons who have taken the time to join us, especially to elaborate on trauma in children, which we very often neglect or don't think about so much. And therefore, I'm indeed privileged to have all these eminent resource persons with us for this webinar. And also, I would like to especially welcome Dr. Simone, our chair of the GICS admin. And also with us, we have Dr. Mohammed, who's the secretary of the GICS, and we are indeed privileged to have them both with us here. And I'm sure we will have introduction of each of the resource persons very soon. And therefore, I would just like to finish here and hand over the session again back to Kay. Over to you, Kay. Thank you.
Thank you so much, Prof. Benita, for that warm welcome. Moving on to our guest for tonight. She's a full professor of pediatric surgery and head of pediatric surgical oncology at the Federal University of Sao Paulo, GRAC Institute, a specialized pediatric oncology hospital that supports adolescents and children with cancer, dedicated to education and injury prevention. She serves as the academic coordinator at Santa Marcelina Medical School and president of Criança Segura Safe Kids Brazil, focusing her clinical expertise on pediatric oncology, trauma, and trauma prevention. Globally recognized for her leadership, she is the president of the International Society of Pediatric Surgical Oncology and currently serves as the chair of the Global Initiative for Children's Surgery. Ladies and gentlemen, it is an absolute privilege to welcome Dr. Simone Abib. Thank you for joining us, Dr. Abib. You may have the floor.
Thank you so much, Kay. Thank you, Vinita, and thank you for all the wonderful specialists that are here present. I think that we start this webinar series with a very important topic, which is trauma. And I am very pleased that this initiative has come through the Nursing Working Group that we value so much. And also bringing together the multidisciplinary vision, bringing together the surgeons, the society for the prevention part also. So I'm very, very happy to have you here. And for those that are still not GICS members, you are more than welcome to join our society, which is very inclusive. And I think that the multidisciplinary approach and also the common purpose, which is surgery in children, binds us to a very important cause. So I wanted you to welcome to our society and to feel welcome to our society. And also, I'm sure that this webinar will be a very successful initiative, and we are happy to support any other activities that follow that. So thank you so much for the initiative and for being here. Thank you.
Thank you so much, Dr. Abib. So moving on to our lecture proper. So I would like to start with our first speaker. He will share with us trauma in children, an overview of life-threatening injuries and its immediate impact on children. He is an award-winning general surgeon from Zimbabwe and currently a postdoctoral fellow at the Nuffield Department of Surgery, Oxford University. He holds advanced degrees from the University of Malawi, the University of Zimbabwe, and Oxford, where he earned a Doctor of Philosophy in Surgical Sciences. Having previously practiced clinical surgery in Harare and contributed to global research collaboratives, his current work focuses on strengthening trauma systems and reducing childhood injuries in low and middle income countries. My dear colleagues, please give a warm virtual applause to Dr. Dennis Mazzini. You may now start your presentation, Dr. Mazzini. I'm going to stop sharing.
Thank you. Right. Thank you. Please let me know if you can see my slides.
Yes. Yes, we can.
Right. So thank you very much, ladies and gentlemen. Very privileged to be here to speak to all of you and to share on this very important topic. It's a topic that is particularly important to me and something that I'm very passionate about. And it's very important that nurses who are our partners in treating and managing patients, and sometimes the first line of defense, it's important to know that you are also as passionate as I am on this topic. So I'm talking specifically about giving an overview of life-threatening injuries and their impact on children. Important to note that this is quite a big topic, and in the 30 minutes that I have, I can't really do complete justice to the topic, but I just want to stimulate some thoughts in your mind that will hopefully help you to think about the right things. What we're going to speak about, we're going to go through some elements of the burden of childhood trauma and the effects of injury on children and society, why children are different from adults, some immediately life-threatening injuries and the way to go about an approach to looking at them, looking for hidden threats and deterioration, how to recognize things early, and emphasizing the importance of reassessment. And essentially, we're going to go from injury to recognition to the immediate impact and then beyond. So injury is a very, very substantial burden around the world. 4.9 million people died from injuries of all causes in 2023, which makes up about 8.1% of all global deaths. And 80% of those deaths happen in low and middle income countries. Although it's important to note that these numbers are likely a significant underestimate because they rely on figures and statistics that are also undercounted, particularly in those low and middle income countries. And so you get a number of 803,000 child deaths annually, which is 12.9% of all global child deaths. So you can see that injury as a proportion of deaths is larger in children than it is in adults. And remember that death is not the only impact that you can have from an injury. So injuries can also happen in substantial morbidity and then other impacts as well. Put simply, more than 1,600 children and adolescents die from injuries every day. It's the number one leading cause of death globally among the 5 to 19-year-old age group. And of all deaths among 5 to 19-year-olds in 2024, 36% of them were due to injury. So this is a really big and interesting and important problem. So injuries have an effect beyond just death, which I've talked about, but they have an impact not only on the child, but on their family, as well as on society. On the child, we are well aware as clinicians of the physical impact on the child. So they cause disability, they cause pain, they cause and the need for rehabilitation. However, they also have effects on mental health, so fear, anxiety, PTSD, particularly in young children. They can have effects on a child's ability to get education, so they can cause school absence because of injury or death, and they can cause disrupted learning, which can have lifelong effects for that child's opportunities. And then, of course, they can cause issues related to development, particularly brain development, participation in school and work, and opportunities in the future. So saving lives is important, but survival is only the beginning of our responsibility. And this is why we care about this so much. On the family, they can have an impact on the caregivers, so time taken, travel required, and long-term care for children who are injured. Lost income from absence from work for the caregivers, lost wages. The costs are particularly high, not only for the patients, but also for the health system, for treating, transporting, and rehabilitating children. And the family well-being is also strained when a child is injured. And then on society as a whole, the healthcare system is strained, particularly in places where children make up more than 50% of the population of a country. Education is impacted, so that has impacts on sustainable development goals that relate to development, education, educational attainment, economy, etc. The economy suffers from lost productivity and inequality. So injury tends to widen inequalities because the people who are the most disadvantaged are the people who are also at the most risk, and the people who are also affected the most when injuries do happen. So it's a vicious cycle of risk, injury, and impact. So injury has consequences that is measured in years and not in days. So how are children injured? So what are some of the causes of injury? And many of them, we know them, but we want to look at the most important, most common ones. Road traffic injuries, falls, drowning, burns, poisoning, and some two important causes, violence and self-harm. Self-harm is actually, depending on the country, either the first, second, or third highest cause of injury, and something that we shouldn't really leave out when we think about injuries. So here are some of the figures from the latest nationally, globally representative data that we have. Road crashes, and you can see here deaths and incidents, okay? So road crashes cause 1.3 million deaths, but that's on the background of 50 million road crashes every year. Falls cause 857,000 deaths, right? So quite a large and a smaller number of deaths, but that's on the basis of 458 million falls that occur every year. Burns, about 1/10 or 1/11 of the number of injuries happen cause death, and then drowning as well. So these are some of the common ones, and then I've left out their self-harm and violence, which are also extremely important and have implications beyond just the morbidity and mortality. So once you've had a cause of injury, what can that do to a child? So this is what we call the result, the pattern of injury. So you can get head injuries, particularly important in children, because the brain is developing in children, and any interruption to that development can then lead to longer-term mental health and cognitive and other effects over time. The chest is a very important part of the body that can be injured in children, particularly vulnerable to life-threatening injuries. The abdomen, okay, so solid organ and hollow viscous injuries can occur. The spine, so spinal column and spinal cord are vulnerable to injury. And the cord can be injured even when the column is not fractured because of the pliability of a child's bones and spine. The pelvis and limbs are also very important, so upper and lower, which can have fractures, vascular injury, or hemorrhage. And then obviously the skin and soft tissue can also be affected by burns, by crush injuries, and other types of injury, and that's particularly in a certain age group of children. And then also remember that you can get multi-system trauma from trauma. So it's not just about isolated trauma, but it's really multi-system trauma can occur. And in any case, trauma is a systemic disease. So it's a disease that affects certain parts of the body, yes, but the effects, the physiological effects of that injury can affect the whole body in a systems manner and lead to large multi-system inflammatory responses that can further worsen the condition of the child beyond what you can see, right? So in children, it's really important to look at what you can see, be good at recognizing what is seeable, but also understand that there's also what we can't see that is affecting the child, and being able to recognize that is very important. So after we look at the pattern of injury, we want to look at the nature of injury. So what can happen in each of those areas? You can get blunt trauma. So that is a blunt force of trauma to soft and hard tissues. And an example of that is road crashes, falls, and crush injuries. You can get penetrating type of injury, for example, stab wounds, gunshot wounds, these are ballistic wounds, and impalement wounds, okay? So either from an animal or from some kind of instrument. Gunshot wounds or ballistic wounds have the extra added feature that they also may include burn, they may include explosions and shrapnel and other things that can occur that can worsen the injury beyond just the penetrating nature. Thermal, electrical, or chemical injuries can come from burns, electrocution, or corrosive materials. And then asphyxia can happen from drowning, from strangulation, and from suffocation, so ingestion of foreign bodies, or even interpersonal violence and trauma. So the mechanism can give us clues, okay, and the injury pattern determines what is the threat to life. So there are certain regions of the body where the threat might be higher because there's a lot of vital organs in a relatively small, limited area. So all of these things are really important to understand, which is what was the cause, what is the pattern that I can see, and what is the nature of injury that can determine what we do and what might happen to the child. But in general, mechanism predicts injury, right? So as we said before, if a road traffic crash or pedestrian is struck, you can expect a certain pattern of injury, okay? And in particular, with car crashes, now notice I didn't say accidents. In injury literature, we don't like to use the word accident because we believe that every incident is preventable, every injury is preventable. So children who get struck by a car as pedestrians have very specific patterns of injury that can occur. One of them is known as Waddell's triad, which basically means a child might get struck on the trunk, then their head might hit the trunk of the car, and then they may also get thrown away from the car and then again get a head injury or lower limb fractures. But then if a child was involved as a vehicle occupant, then you might expect some other different injury patterns. So for example, they may have a head and neck as a result of whiplash injuries, coup or contra coup injuries. They may have chest injuries and abdomen injuries, particularly if they have a seat and lap belt. And they may also have spine injuries. A bicycle or handlebar mechanism might predict that they might have head injury and abdominal organ injuries because the handlebar can cause injury to the abdomen. And then a fall might cause issues that relate to the head and spine, particularly the cervical spine, the neck, and the extremity. So you can see that even if we're thinking about one cause, which is a road traffic crash, the circumstances or the mechanism of that injury can then help us to understand where we look for the patterns that we expect. So you start from cause, you go to mechanism, you go to pattern, where do we expect injuries to be, and then you go to nature, and then that will tell you a very good picture of what you might expect. So mechanism tells you where to look. In significant blunt trauma, assume that multi-system injury is present until proven otherwise. So injury causes change with age, and the reason for that is because risk changes with age. So the things that children are at risk of depends on their age. Infants are vulnerable to falls, burns, suffocation, and non-accidental injury. That is related to the fact that children developmentally are likely to pick up things that they shouldn't, cannot evade hot substances or flame, and also might not understand flame and hot substances, and also can fall because they haven't got the sufficient gross motor skills. Young children can have falls, burns, drowning, poisoning, and pedestrian injury. So as they start to walk, they're now at risk of different things, like falling into a water body, like picking up things that they wouldn't be able to access if they were an infant, and when walking, pedestrian injury. Once they get a bit older, school age, road traffic crashes start to take over quite substantially, and road traffic crash in most countries is the highest incidence of injury, although drowning is also important in some countries. Falls happen as children start to take more risks. Drowning also happens for some of the same reasons, and sport and recreation injuries. And then the same in adolescence. So the age of the child matters in terms of what you think they might be at risk of and what might be happening with them. And across the life course, this can be true as well for particular causes. So you can see here that for road safety, if you're an infant, you're usually not walking, you're in the car. So usually the risk is overall relatively low, although it can happen. Then as you start to walk, pedestrian injuries become important. As you start to particularly become older or adolescent children or use bikes and start taking more risks, your risk also changes. So that's important to understand. So with respect to the title, which was immediately life-threatening injuries, these are injuries that can cause death within minutes to a very short time unless they are recognized and treated during the primary survey. Okay, so these are the things that it's criminal not to be able to pick up. Okay, recognizing and treating immediately life-threatening injuries can save lives and then give you time to deal with the potentially life-threatening injuries. Those are things that may not cause immediate death or physiological collapse, but they can cause death or deterioration over the next minutes to hours after the injury, right? So we start off with those things likely to kill earlier. Then we move to those things likely to kill later. Then we move to those things that are likely to cause disability in the long term. And that's how we systematically go through these things. And that's the basis for many of the guidelines for how we approach injuries, things like ATLS, etc. It's about saving life first, saving limb and disability, and then making sure the child can go back to the community. And in children, the distinction between immediately life-threatening and potentially life-threatening can be very, very small. And it takes a very experienced person to be able to distinguish a child with an immediately life-threatening injury and a potentially life-threatening injury. Because the reason for that is that children sometimes can compensate, right, in a way that is deceiving. They can seem like they're doing okay, but they may have significant injury and then may deteriorate rapidly, particularly if you're not watching and reassessing children. So understand that children can appear like they're okay, but they're very subtle signs that may give you a clue that they are compensating and that they may decompensate eventually. And so this talk covers kind of both of these ones, immediately lethal and the potentially life-threatening injuries in a seriously injured child. It's going to be spoken about later, but the relevant guidelines here are the ATLS guidelines, the most recent one of the 11th edition, which replaced the 10th edition in 2025, but I think both are equally as good. And then there are other non-ATLS guidelines, which are also very important, and some new radiology and trauma guidelines, which also came out recently. But as we said before, it's important to first deal with the immediate threat to life. And the ATLS protocol gives us the XABCDE approach to injuries. And XABCDE is an improvement on the initial approach we used to have, because before A, B, C, D, and E can cause death, X, which is exsanguinating external hemorrhage, can cause death before any of that, right? So if you have a child who's bleeding catastrophically, it doesn't make sense to start with A. You need to deal with the catastrophic external hemorrhage first and then go on to A, even though A is also very important. And I'll tell you what A means later. So XABCDE means we deal with exsanguinating external hemorrhage first, then we go to the airway, the breathing, the circulation, right? And then the rest. So children are very particular physiologically, and there are three main things that can kill children the most effectively, particularly after injury. Those three things are hypoxia, hemorrhage, and brain injury, okay? Hypoxia is just a reduction in the amount of oxygen in the blood and is the end result of airway obstruction, right? So the child is not able to breathe, they're not able to oxygenate their lungs, leads to respiratory failure, can come from respiratory failure, and can come from thoracic injury, right? So either there's something wrong with the lungs that doesn't allow them to take in oxygen, or there's something that's preventing the lungs from taking in the oxygen in the first place, right? So hypoxia, very, very important. It's the common endpoint for a lot of injuries that are life-threatening in children, okay? And it's something that you need to keep a close eye on. So having an oxygen saturation probe can be life-saving. This is the one situation where having a piece of equipment is the most life-saving. Of course, your eyes, your ears, your hands are very, very important, but this oxygen saturation probe is also very important, although observation is the number one thing. Hemorrhage, okay? So external bleeding and internal bleeding, okay, and hemorrhagic shock are also very important causes of death in children. And so that means bleeding you can see, bleeding you can't see, but you should expect, and hemorrhagic shock. So we spoke about the pattern of injury and sometimes how mechanism can predict what pattern we should expect, right? And a lot of the times, the assessment of a child for hemorrhage is really about systematically looking for the places you expect to find the problem and then excluding each one by one, right? So someone who understands the mechanism of injury will have certain patterns that they would expect, and then one by one would go through those particular areas of the body, so like the chest, the abdomen, the long bones, the pelvis, the brain, and one by one tick off those things, making sure that there's no either external or internal bleeding leading to shock, because a shocked child then becomes a dead child. And then brain injury is also very important. Primary brain injury is the injury that happens at the point of contact. Secondary brain injury is the injury that can happen over time due to hypoxia, hypotension, hypothermia, etc. And so it's important that we deal with the primary brain injury, but we also prevent them from getting secondary brain injury as well. So the priority right now is not the diagnosis per se, is to deal with these three things that kill people in a systematic manner, which is the XABCDE. So deal with the immediate threat to life and not necessarily looking for a diagnosis like blunt abdominal trauma or rib fracture, for example. The key is to recognize one of these three, intervene as in life-saving interventions, and then keep reassessing, because as we said, children can hide the fact that they're actually very sick. Children are very brave. They're able to compensate very much, but as adults, we need to be able to understand when a child is actually compensating and has something underlying. It's important to also understand that children are not small adults. So children are not just the same as adults, just smaller, okay? There are some very specific things about children's anatomy and their physiology that make treating trauma in children very different, okay? The airway is different, right? The size of their head with respect to the rest of their body is different. So they tend to have bigger heads, which means they are vulnerable to the head being involved in the mechanism of injury and to cervical spine injury. The brain as well, not only is it developing, but it's also vulnerable to injury, and more so than in adults. And there's all of these other differences here, some of which I will describe for you, are very important to understand in children. Vital signs are very different, okay? So don't expect to look at a vital sign using adult thresholds and then expect to be able to detect a problem, okay? You need to know the correct vital signs for children, and most of them are age dependent, okay? So the important ones are things like blood pressure. You need to understand the normal values for pulse rate, for respiratory rate, and others. And remember that children can maintain their vital signs in a lot of situations, even though something more serious is happening underneath. So don't rely too much on vital signs. Rely more on your eyes, your ears, and your hands to detect a problem, and also a saturation probe if necessary, if available. So things, for example, the airway in children is smaller and it's anatomically different, okay, which means they are more likely to have a blocked airway, which can lead to hypoxia, which can lead to death, as you saw before, one of the causes of death. They have a very large occiput, so when the child is lying supine, it means that the head is relatively slightly more flexed than you would expect in an adult, which means the airway is even smaller when a child is lying supine. The tongue is also larger. They have a narrow airway than adults would. So hypoxia is a particular risk when you're taking care of a child, and for some of these reasons. In their breathing, they have less respiratory reserve, okay? So their ability to continue to breathe and deliver oxygen when things go wrong is less. And they have high oxygen demand, and they have a more compliant chest wall, which can lead to hypoxia, which can lead to death. So remember, hypoxia is the end result, like a common endpoint for death in many situations. In circulation, children have a smaller circulating volume than adults, and they have powerful initial compensation. So their blood pressure might seem normal. Their pulse rate might also seem relatively normal for the situation, but then what might happen is suddenly they will deteriorate and then get hypertension. And if a child is having hypotension, it means that things have already gone very wrong, and you need to intervene very quickly because they've been compensating all this time, and now suddenly they've decompensated. Again, there's a large head-to-body ratio, so they have larger heads. They have different injury patterns based on their size, weight, and activities that they do. They have less protective body mass, so adults might have muscle and fat that can get in the way or absorb mechanical forces, whereas children are really vulnerable to even the smallest forces. They lose temperature quite rapidly because they have a greater surface to area to mass ratio. So hypothermia is a very under-recognized thing that can cause circulatory collapse, circulatory shutdown, and then lead to hypoxia, which can then lead to death. So hypothermia worsens physiology in all respects. It worsens coagulopathy. It worsens everything, really, in children. So it's important to understand these things so you can intervene appropriately. That can mean putting the child when they're lying supine, putting them on a board which excludes the occiput so that the airway can now be relatively in a neutral position. So like we said, children compensate until they don't, okay? So they'll compensate for quite a long time, and then when they decompensate, that is when they are really in trouble. Serious injury may be present before a child looks seriously unwell, so they can look well, but they're not. So how do we find these threats systematically? Like we said before, you look for immediate threats to life, then you look for potential threats to life, and you do them systematically, and then you do them with a mind to the different patterns of injury you would suspect, and then systematically rule out a problem in each of those areas until you are left with the exclusion of severe life-threatening injuries, okay? And this framework here, which we've talked about, the XABCDE, exsanguinating hemorrhage, airway, breathing, circulation, disability, neurologic status, and exposure plus environment. So you don't need a diagnosis, you just need to deal with the X, A, B, C, D, E at first. So X, catastrophic hemorrhage, like we said, stop the bleeding, right? So external bleeding that you can see, you need to stop the bleeding with a variety of different ways, which I don't think we'll go into now. We don't have much time. Serious injury may be present before the child looks very, very ill. So stop the bleeding if it's external. If it's internal, stop the bleeding as well. So you need to detect the bleeding and then stop it in a variety of ways. For example, if it's abdominal injury, in many situations, it can only be stopped by an operation, for example, but not all the time. So how to do this? You need to look, control, and don't delay. So look is not just about looking with your eyes. Look is a wider term that means recognize, right? And you look smartly, which means you look in places you know you're expecting to find something if something was wrong. So you rapidly identify life-threatening bleeding, whether it's external or internal, and then you stop that bleeding, right? So that means if there's no external bleeding but a child looks shocked, okay, then start to look for problems in the abdomen, in the chest, in the long bones, in the pelvis, for example. Then control. So control the wound, the bleeding either with direct pressure, wound packing, a tourniquet if indicated. This is a very dangerous intervention, so be careful about using a tourniquet. And then don't delay. Take them to theater if they need to go to theater. Take them to the interventional radiology suite if you need to do that, or call for help. Right? Ask for the surgeons to come to stop bleeding if it's occurring, especially if it's catastrophic, because that's what's going to kill the child before anything else. Airway. So airway obstruction. Remember we said this is very important because airway obstruction can rapidly lead to hypoxia, which can lead to death in children within minutes. So you need to look, listen, and act. These are the three things that you need to do. Look at chest movement. Look for retractions. Look for agitation. So something as subtle as agitation in a child or reduced consciousness can let you know that there's hypoxia or something going on. Listen, use your ears, stridor, snoring, gurgling, or silence is a very important sign that something could be wrong. Act. So open and position the airway. That can mean putting the head in the neutral position or putting the head off a headboard. It can mean suction or remove obstructions. It can mean giving oxygen or giving ventilatory support and escalating early. So looking for the anesthetists or the casualty doctors to establish an airway as quickly as possible. A child who can talk or cry generally has a patent airway for now, but remember that can change, okay? Then life-threatening chest injuries. This is the first of the major life-threatening injuries in the chest. You can remember air in, air out blood, and I'll show you what that means in the next slide. But there are a variety of important diagnoses that you cannot miss. It's important not to miss. The lethal 6 are a list of injuries that can happen in the chest that you must not be able to miss. So air in, tension pneumothorax. Air out, open pneumothorax. And then blood, massive hemothorax, right? So tension pneumothorax, accumulation of air under pressure in the pleural space that compromises cardiovascular function. Open pneumothorax is a chest wall defect that allows air to pass into the pleural space. Massive hemothorax is a large amount of blood in the thorax, leading to issues with breathing mechanics. Airway obstruction, again, very, very important. Physical blockage of the upper and lower respiratory tracts. Cardiac tamponade, is number 5. So this is accumulation of fluid or blood in the pericardial sac, preventing the heart from beating, and it restricts cardiac filling. And then flail chest, which is 2 or more ribs broken in 2 or more places, creating a paradoxical movement of the chest wall. So usually you would expect breathe in, chest expands, breathe out, chest goes in. But you can get paradoxical breathing where it moves, a section of the chest might move differently to how the rest of the chest is moving. And so your eyes can be really important, a very subtle thing to see, and that's why eyes are so important, and that's why you have to specifically look there because you expect that there may be something going on there. Hemorrhagic shock is also extremely important. Stop the bleeding. Again, look, control, and don't delay. Same thing. You need to identify where the bleeding might be, overt and occult sources of blood, or blood bleeding you can see and bleeding that you can't see from outside. and don't delay. Most important thing. And children hide blood in various places. So the chest, the head, the abdomen, the long bones like femur fracture or upper limb and lower limb fractures, the pelvis, okay? So look for those places in particular. And then severe traumatic brain injury. It's important to recognize it, right? So a reduced Glasgow Coma Scale, which is relatively easier to assess in adults, right? But in children can be very, very subtle. It can just be altered behavior. Mother says he's not acting like he usually would act, all right? Unequal or abnormal pupils, seizures, and focal neurological signs. So without seizures and focal neurological signs can be very, very subtle. And you have to really look hard and look deliberately. Then watch for deterioration. So you need to be constantly reassessing, is the Glasgow Coma Scale or the Pediatric Glasgow Coma Scale or other types of coma scale, Blantyre Coma Scale and others, is it falling? Is there a change over time? Were the pupils normal but have now changed? Do they have an abnormal posture or do they have abnormal breathing? And then, of course, remember we said there's primary brain injury, then there's secondary brain injury. So you need to avoid hypoxia, which can cause brain injury secondarily. You avoid hypertension, which can cause hypoxia, which can cause secondary brain injury. And then you need to maintain ventilation and perfusion, because a child who is breathing fast, who is tachypnic, can then become tired and then no longer ventilate and perfuse as they should be. Then you need to keep reassessing, because children can change very quickly. The first injury has happened, now you need to prevent the second injury. Then exposure and immediate threats, you need to expose to find. So you need to expose them first to look, then cover to protect, okay? So you look everywhere, you fully expose, you turn them around, look on the front, look on the back, look in the skin folds and the crevices, look for hidden injuries, and log roll the child where it's appropriate. Where there's a risk that they might have C-spine injury, you need to log roll them instead of just rolling them. Don't miss wounds and bleeding, burns that can accompany even mechanical injuries, deformity and fractures, and bruising or swelling, which can be difficult to see in a chubby child with lots of subcutaneous fat. And then keep the child warm. So once you've had a good look, then cover them, keep them warm. Remember, hypothermia is a very important thing that can occur in children and that can lead to adverse events. Beyond that, we look for places that we should not miss out. So the chest, contusions, pulmonary contusions may evolve over time. Child was okay at first, now is getting worse. The abdomen, so you want to be careful about looking for occult hemorrhage in the abdomen, right? They can have injury to the solid organs, the spleen, the liver, the kidneys, or they can have injury to hollow organs like the intestines. And the signs may be very subtle and shock may be compensated. So get the advice of a surgeon and use adjuncts to therapy whenever necessary. So that can mean imaging, it can mean fast scan, it can mean a variety of different things. And then the brain, you want to look at intracranial injury, particularly as it evolves over time, right? And that's true for everything in a child. They evolve over time. They might seem fine beginning, they're crying, they have a good blood pressure, they look okay, but then an hour later, they may be decompensated. The hidden six is another set of potentially life-threatening situations that can happen or immediately life-threatening. Things like thoracic aortic disruption, injury to the aorta, tracheobronchial disruption, injury to the bronchia, the bronchi or trachea, myocardial contusion, that's a blunt injury to the heart muscle, traumatic diaphragmatic tear, a rupture of the diaphragm, esophageal disruption, a tear of the esophagus, and pulmonary contusion, injury to the lung parenchyma. And together, the hidden six and the lethal six are called the deadly dozen, right? These are the 12 major injuries that can cause deaths. So recognizing deterioration is an art and in many situations, and needs us to take all of our senses into play. Looking at circulation, so their heart rate may start to rise slowly. The peripheries may be cool or they may look mottled, particularly in people with light skin, but in people with dark skin, that may look very subtle, a subtle change in the color. Prolonged capillary refill, very important, very useful sign. Keep checking the capillary refill in children and the falling urine output. Breathing, the respiratory rate might start to go up, okay? So it may look like they're being more active, but actually what that means is that they're actually becoming sicker, they're increasing their work of breathing, which means they can get tired, become hypoxic, and then start to fatigue. Neurology, look for agitation, coma, a difference in the way they're acting, drowsiness, and a fall in GCS over time, as well as the change in their pupils. And then look for signs that are late. This means you've missed something and now they've already become really, really sick. So hypotension happens late. Bradycardia happens after that. That's even later. Apnea and unresponsiveness. So these are the things that happen very late, and you have to do something immediately to avoid death. And then again, you do that again and again and again. You repeat and repeat until the child is out of the woods. So reassess, keep reassessing. So I've given you a lot of information. So I just want to go through some things to remember, just so that you can go away with something that you can remember. So children are different to adults, right? The anatomy, the physiology, and the injury patterns are very different. So the way you look for injury, sometimes you're searching for injury as opposed to just necessarily treating it or recognizing it. Sometimes you're searching for it. You'll search in specific places based on this anatomy and physiology. You treat what kills first: hypoxia, hemorrhage, and brain injury. A normal blood pressure doesn't mean a child is stable, okay? They compensate until they don't. Serious injury may be hidden, and so the mechanism really matters, and you need to keep reassessing. Trends save lives rather than what you see in the moment, right? So you need to recognize that a trend has started to change. The blood pressure has gone down, the pulse rate has gone up, the breathing rate has gone up, the GCS has gone down over time. Then you need to escalate. So have criteria for escalation. When you see a trend has changed direction, intervene quickly, reassess, call for help, right? Early recognition changes outcomes, and early recognition changes outcomes. I think it bears repeating. So in conclusion, pediatric trauma is a time-critical condition. Life-threatening injury can progress rapidly, while early signs can be subtle. Children require a pediatric lens. So you need someone who has seen and treated pediatric patients a lot, or who is sensitive to the things that they should be looking for, okay? Very different from adults. And then early recognition changes the trajectory. So if you recognize early, suspect early, call for help and intervene, then you can save a life. Thank you very, very much for listening.
Thank you so much, Dr. Dennis Mazingi. That is a very wonderful sharing related to trauma in children. I particularly like the look, control, and don't delay. That approach is truly anything related to pedia is critical. So please stand by for a while as we go through another speaker. So we'll wait for our question and answer in a few. So moving on to our next speaker. Okay, so she is a prominent nursing professional and healthcare education in India. She's an associate professor in the College of Nursing at the Christian Medical College in Vellore, South India. Her research and clinical work focus extensively on pediatric healthcare, particularly in improving the hospital experiences, sleep quality, and psychological well-being of hospitalized children. She has also authored qualitative studies investigating the traumatic experiences and coping needs of primary caregivers with children admitted to pediatric intensive care units. To discuss the topic on beyond survival, holistic and trauma-informed nursing care, please join me in extending a warm welcome to Ms. Shanti Gladstone. Take it away, Shanti.
Happy evening to all of you. Am I audible?
Yes, you are.
Okay. I thank Dr. Vinita and the GICS administrator and team for giving me this opportunity. Okay, my topic for now is Beyond Survival, Holistic and Trauma-Informed Nursing Care. The Centers for Disease Control and Prevention defines a trauma event as a frightening, dangerous, or violent event that poses a threat to a person's life or bodily integrity. And it is based on the three framework, that is event, experience, and effect. Event is the actual occurrences which can be physical threat, an emotional shock, a sudden loss, or prolonged neglect. Experience refers to how the individual perceives and processes the event. And the effect is the long-lasting adverse impacts on the person's mental, physical, social, emotional, or spiritual well-being. Trauma-informed nursing care is an approach where nurses treat every patient with the assumption that they have a history of trauma, shifting focus from what is wrong with you to what happened to you. What is wrong with you is focuses on symptom and the disease and helping an individual to be free from the symptoms. In what happened to you is looks at experiences and treats the behavior, working together to help the individual to get a complete healing. I would like to start with a case study. A 7-year-old girl presented with a history of flame burn 7 hours before admission to pediatric emergency service. She was apparently playing around her home when burning hay fell onto her back and her clothes caught fire. When she came to emergency service, she was found to have deep partial thickness burns, that is second degree, involving all parts of the body except the chest, abdomen, and gluteal. These are the core nursing care we were able to concentrate on this child. This is not only for a child with burn, it applies to any children come with any kind of injury. The first one is safety, next is collaboration, third one is empowerment, trust and transparency, and last one is cultural and spiritual care. When we talk about safety, it includes physical and emotional safety. Physical safety related to this child is first one, shock management. When she came into ED, she was in hypotensive shock, and so we were able to administer oxygen, and fluid resuscitation was started for this child with ringer lactate, dextrosaline, and inotropes like adrenaline infusion. Next goes on to pain and sedation management. She was continuously put on injection morphine 1 milligram per hour. Whenever the dressing was changed, she was given injection ketamine prior to dressing to be free from the pain. Infection control, we were able to follow strict hand washing technique, and she was admitted in intensive care unit after stabilization from pediatric emergency. So she was received to single room where the infection can be prevented, and all the nurses were strictly following wearing personal protective equipment and strictly hand washing, and the dressing was done following the aseptic precaution, and strictly we were restricting the visitors except the parents and one at a time at the bedside, and all the sheets were sterilized and it was given to her. Early mobilization we could not do in intensive care unit. Once she was moved out from the ICU, she was able to mobilize. Inside the ICU, we were able to give passive mobilization like turning the position and helping her to flex the hands and knees. When it comes to nutritional support, she was given Burns feed, which has high calorie and high protein. This is about physical safety. So child did not develop, child was recovered from the shock, and child could not feel the discomfort when the dressing was done, and child was free from infection. She did not develop any bloodstream infection or wound infection, and no contracture, and child weight is improving now. Coming on to emotional safety, the first one is orientation. When they came into ICU, the child and the parents were oriented to all the team members in the intensive care unit, like doctors, nurses, technician, and other supportive care staff. All the routines were explained to the child, like what are the kind of procedures will be done for the child, and what are the different kinds of equipment will be used, how the alarm sound of infusion pumps, cardiac monitor, ventilator, everything was explained to her. And we were able to reduce the environment induced anxiety by putting her in a single room and with the parents. So this was a big support. Parents were the big support for her to reduce the stranger anxiety. And we were able to screen her for mental health. After getting into ICU, second day, she started having visual hallucination. So we were able to talk to the parents, and the child was referred to child adolescent psychiatrist, and counseling was given. And also she was started on lorazepam tablet for a short period, mild dose, and after that she was not experiencing any threatful events. The next care is collaboration. Coming on to collaboration, the clinical team were able to give the clinical choice to the parents and the child on early mobilization, kind of dressing and the type of dressing, what kind of diet the child should take, why there is a need for child adolescent psychiatrist counseling, and what kind of surgical procedure will be done, that is grafting. Everything, all the choices were given to the parents and the child, and we were allowing them to take the decision from their side, and they were so happy after explaining all this management, and child underwent all the management, and child is doing well now. The next care is empowerment. In empowerment, the choices were given to the child, like non-critical procedure choices, like changing the bed, changing the sheet, vital signs, and time for giving feeding, and position changing. All these were informed to the child, and we were asking her to give the choice what time will be the convenient for the child to do all this procedure. Based on that, we were not compelling the patient on non-critical procedures. And the environmental control, by as per her likes and dislikes, we were able to provide the room light, and changing the position of the child, changing the position of the bed, and whatever the child needed, interested in the play, we were able to show the video. Sometimes she will ask for a mobile video, sometimes she wanted to listen to music, sometimes she wanted us to tell the story, sometimes she wanted the mother to tell the story. So everything was, we were be able to flexible with the child whenever, whatever she was asking. And physical boundary choices, every time whenever we used to touch the child for giving injection or changing the position, changing the sheet or gown, we were able to get the oral consent from the child. After that only we were able to touch the patient. Next is trust and transparency. In trust and transparency, the team was able to give honest information to child. Whatever we were doing, the same thing was informed to the child and the relative. There were no miscorrelation, nothing like that. Whatever we were saying, it was correlating with the action, what we were doing. And we were able to utilize the burns nurse specialist to give her the accurate information on her condition, on her improvement, on her teaching, and she was able to explain to the child and the family in future how this trauma can be prevented. And we were also able to follow the strict stop signal. That means the child would want to say every time that, sister, when you do the dressing, I will start counting 1, 2, 3. When I stop the count, you should stop doing the dressing. That means she says that whenever I feel discomfort, I will stop my counting. So the same scenario we were able to follow throughout the intensive care and also in the ward care when we were doing this dressing. She used to stop at number of 3 or 4. That time the nurse used to stop doing the dressing. So this was the encouragement for the child to cooperate for the dressing. And all the time we ensure that the one of the parent is present at the bedside. So whatever we were explaining to the child, we were able to explain to the parents also, so that we could get good cooperation from both the parents and also from the family. The next one is interdisciplinary rounds with the family. Whenever the doctors, nurses, technicians, and paramedics, nutritionist or dietitian do the rounds, we were able to include the family, and we were allowing them to express their feeling about the child's condition, about the management, about the prognosis, about the cost, how much it will take during the intensive care. So when we gave them the time way for them to express, they were able to express a lot of queries, and all that we were able to clarify during the interdisciplinary rounds. The last one is cultural and spiritual care. This is very, in Indian context, most of the adult as well as the children will feel that whenever they get some trauma, injury or any disease, it will be from God for their like a punishment or result what they have done a mistake. So all the feeling, all the thoughts they will usually have. So we were not very strict with our ICU rules and regulation or policies. Many of the time we were able to be flexible during a visiting time and dressing time, feeding time, checking the vital signs. So every time we used to be flexible with the ICU and institution rules and regulation. And we also ensure that all the time the privacy and confidentiality is maintained about the child and the parents. And the nurses also are instructed in the ICU that they cannot share anything about the patient to non-treating team, though they are the relative. Without the permission of the child and the parents, the details of the children should not be letting out. So we were strictly maintaining the privacy and confidentiality. And coming to the spiritual aspect, in ICU regularly, since it is a Christian institution, always we start with the prayer, and we write all the children name. By telling the children name, the nurse used to pray along with the family. So this was one of the comfort zone for the patient. They were satisfied that the nurses are praying for my child. So that assurance they have. And whenever they needed extra help, we used to call the priest. We have a chaplaincy department. We used to call the priest, and they used to come and counsel the parents and the child. They also used to pray for them. And coming on to counseling, in pediatric ICU, we have 2 sessions every day. Doctors along with nurses, with the parents, the counseling will take place morning and evening for at least half an hour. So during that time, every detail, single detail about the patient, child will be informed to the parents. And whatever the doubts they will have, it will be clarified during the counseling time. And we have a social worker. She will talk to the family and the child, and she will arrange for the financial help or how they can get the social support from other people. Everything, all the details will be informed to the family. And we ensure that during her stay, that she was treated fairly without looking at her any background. So her identity was respected, and she was considered as one of the family member in the ICU. We made her not to feel that she's a patient. It is a strange environment. So the ICU was child friendly for her. So she was able to cope with all the intervention and management, whatever was done inside the ICU. Okay, after 5 days of intensive care, after she was recovered from hypoxia and shock, she was able to mobilize to burns unit, and now she's doing well. The graft is done, the wound is completely healed. The parents are very happy. We don't see externally, we don't see any kind of trauma the child or the family is having. Still, we are going and visiting the child. The burns unit is next to ICU. Okay, these are the standard care we follow for any kind of injury, trauma, road traffic accident. We do get many children with road traffic accident, and during that time, if in case of head trauma, like previous resource person said, we maintain neuroprotection by positioning the child, checking the intracranial pressure, looking for a sign of any seizure, and taking care of the temperature, GCS, maintaining the GCS, everything we used to follow. If they come with compromised ABC, airway, breathing, and circulation, immediately the priority will be ABC. They'll be intubated, they'll be put on ventilator, and all kind of nursing care related to ventilator will be taking care, and breathing will be taken care, and circulation by fluid resuscitation, inotropes, and blood transfusion, all this will be done. These are some of the nursing care we follow for any child coming to pediatric ICU. To conclude, I would like to say that trauma-informed care fundamentally transforms medicine by shifting the clinical focus from patient pathology to personal history. By embedding safety, transparency, and patient autonomy into daily workflows, healthcare systems actively mitigate the risk of clinical re-traumatization. Adopting this framework not only improves patient health outcomes, but also strengthens institutional resilience against burnout. Thank you.
Thank you so much, Shanti, for that insightful lecture. The informed nursing care for pediatric patient. We appreciate you sharing a case study and actual patient scenario. Please stand by as we move on to our next speaker. Okay, our next speaker is a prominent Brazilian healthcare educator, researcher, and university professor. He holds a Doctor of Philosophy in Interdisciplinary Surgical Sciences from the Federal University of Sao Paulo and a master's degree in Biomedical Sciences. Currently, he serves as a professor and coordinator within the nursing and postgraduate health programs at the Herminio Ometo Foundation in Araras, Sao Paulo. He specialized in urgency and emergency care and is the founder and director of the Traumatology and Emergency League, where his work focuses heavily on emergency simulations, first aid training, and accident prevention education. We are incredibly fortunate to be joined by Dr. Antonio Francisco Peripato Filo. Dr. Filo, the virtual floor is yours.
Hi, everyone. Just a minute, please. Can you hear me?
Yes, we can.
Okay. It's okay?
Yes, we can see your slides, Dr. Philo.
Thank you. Well, hello, everyone. It's a great pleasure to be here today. Before I begin, I would like to sincerely thank GICS for this invitation. I feel very honored to be here and especially grateful to have the opportunity to contribute, even in a small way, to this important discussion about pediatric trauma prevention. It's a privilege to share this moment with my colleagues from different parts of the world. Thank you for giving me this, please. Today, I would like to take you from the epidemiological reality of childhood injuries to some practical strategies that we can use to prevent them. And I would like to share not only concepts, but also experience from Brazil. And well, I would like to start with this question. How many children need to get hurt before we understand that accidents are not accidental? This question became one of the foundations of our work because we call something an accident. Sometimes we create the impression that it wasn't predictable. But many childhood injuries are predictable. And if they are predictable, they can often be prevented. So instead of asking only how we treat an injured child, we should also ask, why did this injury happen in this first place? Now, let's look at the Brazilian reality. In 2025, more than 28,000 children were hospitalized because of injury. This means approximately 357 hospitalization every day, or about 15 children every hour. Look at this distribution on the right. Falls represent the largest proportion, followed by burns and traffic-related injuries. And there is one number that I would like you to remember. During this 30-minute presentation, approximately 7 Brazilian children will be hospitalized because of this injury. 7 children. While we are talking about prevention, children are still being injured. And trauma is not an isolated event. This shows the cascade of trauma. And we have a predictable event, then we have the injury, show here. Then we have the injury, then after the injury, we have the hospitalization, and surgery, disability, physiological consequence, and long-term sequelae. So the earlier we intervene in this cascade, the greater our opportunity to change the outcome. Prevention acts before the injury becomes a clinical problem. And we are engineering our way in the wrong direction. This brings us to another important point. Trauma is not a simple bad luck. This distribution of injuries is influenced by where children live, how they move, where they study, and how safe their environments are. Regional inequalities show us that trauma is also a public policy issue. When the environment is unsafe, children are exposed to predictable risk. So we need to stop thinking only about individual behavior. We also need to think about systems. We also need to think about environments. And this slide shows the predictable hazard, the preventable injury. This is one of the central ideas of our presentations. If we will know children get injured and where these injuries happen, then we know where we need to intervene. And prevention requires us to look at 3 important elements: the environment, the supervision, and the human behavior. We cannot place our responsibility on the child. We have to make the environment safer. Well, the next question is, how do we intervene? The framework presented here is based on three complementary strategies. First, education. We need to dialogue and clear rules. Second, the engineer. We need to modify environments to make them safer. Safety nets, child-proof locks, safer institute, and safer roads are example. And third, the enforcement. We need to have rules and legislation that make safety mandatory. Education is important, but education alone is not enough. We need to engineer the environment to protect children. Well, this shows the safety house blueprint. Let's bring the concept into the home. This slide shows how we can map risks according to different areas of a house. In these stairs and windows area, the priority is prevention of falls. In wet areas, the focus is drowning prevention. In the kitchen, burns are the major concern. And the important idea is that prevention can be very specific. We don't need a generic message saying be careful. We need to identify the hazard and define the appropriate action. Well, the global enemies of the childhood. When we look at the childhood injuries globally, 6 major threats repeatedly demand on our attention. It's not different in Brazil. They represent the highest volume of the admissions in dataset: burns, traffic injuries, suffocation, poisoning, and drowning. These mechanisms are different, but they have one thing in common. There are opportunities for prevention. Well, we need to look to this slide through an adult's eyes and through a child's eyes. This is the same picture, but look at what they saw. We need to look at things if you were the children. Prevention also requires simple, standardized procedures, and example, chemicals should remain in their original and clearly identified containers. They should be stored high and completely out of children's research. And we should never create new solutions by mixing chemicals. These may sound like simple recommendations, but simple recommendations became powerful when they become standard procedures. Well, but prevention cannot stop at home. Children spend a large part of their lives at school, so prevention needs to become institutional. This means safe external infrastructure. It means traffic control around schools. It means hazard mapping. It means internal emergency protocols. And it means trained teachers prepared in first aid. Prevention must leave the living room and become institutionalized in our schools. The next question is whether prevention can generate measurable results. In our experience here, we observed important changes in the system after the intervention. But I want to scientifically careful here. The total number of the pediatric trauma attendants did not decrease in absolute numbers. However, the total number of the emergency calls increased substantially, and the proportional represented by pediatric trauma decreased from 6.5% to 6.7%. So, rather than claim a simple reduction in trauma, our experience suggests a more complex effect. Prevention needs to be evaluated together with changes in exposure, reported emergency activation, and system organization. Well, prevention is also about collaboration. We need to clear communication about where people feel supported to report accidents. Professionals need to provide patient and caregiver education. Scientific society and city needs to support research, advocacy, and public police. And perhaps most important, leadership needs to set the example for them. Well, prevention and preparedness are connection. When an emergency happen, the first few seconds matters, and the first step is to access, stay calm, and make sure the scene is safe. The second step is contain the situation. Do not offer food, water, the first aid, and call specialized help immediately. In Brazil, it means SAMU and fire department. We show this in our presentation for the teachers and the families. Well, but what we have in Arara, São Paulo, Brazil. Now I'm gonna bring you one of the show that we have here. More specifically, like in Araras, the city of the state of São Paulo. Araras has approximately 1,030 inhabitants. Our intervention focused on 47 municipal schools, and the object was to evaluate and quantify initiatives designed to prevent unintentional injuries in environments where children spend a significant amount of the time. This became the central settings of my research. And we used a two-pronged evaluation strategy. First, we look at inside the school. We assessed classrooms, sport areas, internal records, and playgrounds. But we also look at outside the schools. We evaluate the immediate road environment and journey children take to reach the school. This was important because the school safety does not end at the school gate. The child needs to be safety inside the school and one of the way of the school. And for the external environment, we use the star rating for a school. This system allows us to objectively evaluate the road environment around the schools. It considers elements such as sidewalks, crossing, speed limits, and warning signs. And importantly, it transforms a complex and sometimes subject to perception of danger into a measurable star rating. In our study, 46 schools were included in the external star rating for school assessment. And Araras, our city, became the first city in the world to have all its seats rated. Well, the Zambia case most illustrates the potential of predictable safe planning. Instead of asking only how safe this road today, we can also ask what will happen if we change the environment. We have two pictures of this school in Zambia here. We can simulate potential interventions and estimate how the safety rating may change. This is extremely important when resources are limited. So Data can help us move from describing problems to strategically allocating resources. And but infrastructure alone is not enough. We also need people who are prepared to act. In our intervention, 898 education professionals receive in-person training in trauma prevention and first aid. More than 1,100 complete the one-line prevention models. We also empowered 171 municipal guards and created school brigade members. This was an important lesson for us. A safe environment needs prepared people. And the second and the third pillars were about to standardize the responses. We implemented a standardized approach for the emergency in the school. The first question is, can the situation be safely managed at the school? And if it's not, there is an immediate escalation to the emergency service. Parents are contacted according to the protocol, and we also implemented standardized first aid kits and standardized procedure across the 47 educational facilities. The objective was to reduce hesitation and improve the response during the trauma. Well, this slide summarizes what the intervention looked like and practice. We did not use only strategies. We combined education, first aid and training, school brigades, and collaboration with municipal guards. This is important because the best protocol is useless if the people on the ground do not know how to use it. So our approach was not only to create protocols, it was to train people to do and to use them. In the synthesis, and this brings us to one of the most important lessons for our experience. Prevention cannot work alone. Health has essential role. Public security has an essential role. Education and public administration also have essential roles. Health provide protocols, emergency integrated, and scientific logics. Public security contributes to rapid responsive and safer environments. And education is where children spend a large part of their lives. True prevention requires continued dialogue and integration public policy. The next question is, can this experience be replicated? I believe it can. Not necessarily by copying every intervention exactly, but by adapting the principles. Access the risk, use data, establish a simple standard, training people, create protocols, monitor what happens, and continuously improve. Prevention does not always require sophisticated technology. Sometimes it requires organization, leadership, and commitment. Well, none of this was done alone. We need help. This slide represents the partnerships behind our project. These partnerships were fundamental. And this is another lesson. Complex problems require coalitions, not isolated professionals. Well, one of the important components of the project was the daily prevention course. The course was offered to the municipal educational network. We had more than 1,000 people enrolled. And among the participants who completed both of the pre-test and post-test, we observed an improvement in the average score from 8.7 to 9.3. For me, this demonstrates an important principle. Knowledge is one of the tools of prevention, but knowledge needs to be transformed into practice. We are now working for translating this core to several languages in Criança Segura, Safe Kids. And in some months, we have this course being translated to several languages. Well, I would like to finish with this message. Accidents happened. Traumas were preventable. Prevention begins long before the emergency. It begins when we design a safer house. It begins when we build a safer school, when we create a safer road, when we train a teacher, and when different sectors decide to work together. As health professionals, we are trained to treat injuries, but we also have to responsibility to ask, could this injury have been prevented? Well, I would like to thank you and thank you very much for the opportunity to share the experience and thank the GICS for keeping children at the center of this global discussion. Thank you.
Thank you so much, Dr. Philo. Just to highlight the question you posted a while ago, how many children need to get hurt before we understand that accidents are not accidental? Truly preventing pediatric accidents is doable, as you have given emphasis in your lecture. Please stand by as we listen to our next speaker. It is my pleasure to welcome our next distinguished speaker to give his summary comment and share the pediatric trauma management. He is an associate professor at the University of Khartoum and currently serves as a consultant and chairman of the Pediatric Surgery Department at King Saud Medical City in Riyadh, Saudi Arabia. A foundational leader in regional surgical education, he's a former convener of the Sudan Medical Specializations Board Pediatric Council and a founding member of the Sudanese Association of Pediatric Surgeons. Please join me in extending a warm welcome to Dr. Abdel Basit El Sayed Ali, as he shares his extensive global and clinical expertise with us today. Dr. Ali, you may now share your screen.
Thank you very much. Can you see my screen?
Yes.
Okay. Right. Yes. Thank you very much. We have heard from few speakers a great deal of information about pediatric trauma, the etiology, the approach to management from the medical side and from the nursing side, and the prevention, which is also crucial. So in this presentation, I'm just going to go briefly to re-emphasize some of the points mentioned and maybe add a few more points in relation to some guidelines and the GICS Pediatric Trauma Care Initiative. So as you've heard, trauma is it's a different and it's a universal disease. Unlike many other diseases that we know of, there is no exemption. Nobody is exempt anywhere from the incidence of trauma. It is for the clinical team and the medical staff and those who are working in the emergency departments, it's a very unpredictable issue. You don't know when a trauma patient will come in. For the families, they don't know when it happens, as we heard earlier on from from some of the speakers, that a child is very vulnerable to trauma. They may be playing around happily, and all of a sudden they get themselves into one serious incident, especially outdoors, where they can easily slip and run on the roads, and they can be easily hit by cars, considering their small body size, and they are not seen by many drivers, as well as their unpredictable behaviors, and their attraction to very serious things, such as the nice presentation by Antonio, as to how these children perceive the serious and dangerous items at home as toys. Trauma can also be of various severity and complexity. And overall, as you have heard, it's a very common cause. In fact, it is the commonest cause of mortality and morbidity in children, exceeding those due to other major diseases collectively. And unfortunately, most of these incidents occur in low and middle income countries, which add to the already existing burdens of socio-economic deficiencies. So again, as Dennis mentioned, children are not small adults, and we should not be treating them like adults and try to minimize our equipment or our approach protocols to children. Children have got their own unique physiology, anatomy, and even psychology. And there are so many causes, as mentioned earlier. They vary, but we need to take into consideration that there are some causes of trauma which can be indoors or outdoors. Some of them can be related to particular communities. So these are some of the common problems that children may encounter. And these are now of growing incidence, the ingestion of dangerous foreign bodies such as the bottom batteries and the magnets. In some communities, you may have very unique types of injuries, such as those in some places in the mid areas of Sudan, where animal pulled carriages, which carry water barrels, have got this pivot. And once it is disconnected from the animal, you see children come to swing and play with it, and it falls on them, causing very serious injuries indeed. And of course, we should not omit the war zone injuries, which are occurring in many places all over the world. Of course, in addition to the natural disasters. So children can come with various types of injuries that we have to take care of. As Antonio mentioned, that there are so many injuries and deaths occurring as we speak. And by calculations of approximately 900,000 deaths every year out of the 5 million deaths worldwide due to trauma, if you with simple calculation, you can find that there are approximately 2 children deaths every minute. Trauma requires a multidisciplinary approach, cannot be a one-man show or one department function. And the role of nursing here is very crucial, as we'll see in a minute. There are clinical practice guidelines which are set for effective and efficient performance and to improve the outcomes. And we'll talk briefly about some of these. So given the complexity of trauma care, continuous specialization in nursing is crucial to enhance the quality of interventions and to improve the outcomes in children. How does that work? In my opinion, that the nursing work on pediatric trauma represents the matrix and the dynamo of executing most of the trauma care plans and the management. The role is crucial in all aspects in relation to the care for trauma, from the scene, if they are involved with the emergency medical services, or from the triage in the emergency department up to the operating room, on the wards, in the pediatric intensive care unit, and even when they are involved with other teams such as the physiotherapy, the stomach care, the rehabilitation, the wound care, in addition to what was mentioned nicely by Shanti about the psychological role, the cultural role, and the spiritual role, and the other kinds of support with dignity and confidentiality. Of course, also observing in all that the safety approach in the management of children, as mentioned by Shanti. So the role of nurses in the management of pediatric trauma is not just a complementary role, it's actually integral. It's in the heart of the appropriate care for children with trauma, and their role is certainly indispensable. In addition to that, they are pretty much closer to the children most of the times compared to the rest of the medical team. Right. So just to go briefly on, to reiterate on the approach to an injured child, and you will find these ABCs or the ATLS guidelines representing the baseline in the management of trauma worldwide, whether for adults or for children, and which, as explained by Dennis earlier, includes the exsanguinating bleeding, or previously was called the C, to be C, A, B, C, D, E, to include C for the visible exsanguinating bleeding that needs to be stopped instantly because it's the main cause of mortality in children with a trauma. And then to come to the airway, breathing, the circulation, which here includes maybe hidden sources of bleeding or abnormal vital signs, vital sign decompensation due to hidden bleeding, or bleeding that has happened before the patient arrival and the patient comes in a state of shock. And of course, the disability, the Glasgow Coma Scale, the modified Glasgow Coma Scale for children, and the AVPO, which is the AVPO is the short for A, the child is alert, V, child responds to verbal and communicates verbally, and P, the child only responds to pain, and O or U, which is for the unresponsive child altogether. So it's a simple, straightforward acronym for assessing a child, especially young children, with major trauma. So you find this as baselines for the approach in the management, but we add to that of course, the secondary survey, which is carried out usually by the the medical team, assisted by the nursing team. In fact, all those who are involved in the management as trauma team can carry out the tasks of conducting all the ABCs and the secondary survey. In addition to the roles of recording, managing documentation, tracking time milestones during the resuscitation and the initial trauma care, and provision of the equipment, and closing the loop with communication. All these are essentially duties carried out by the nursing staff in the trauma care situation. In addition to this, of course, in addition to the D as disability, we add you reduce the distress in these children, and you have to care for their situation regarding the pain and their fears and worries, because as I mentioned, the children have got different psychology, and here they need more reassurance when they are alert or awake following a state of trauma, coming to an abnormal environment in the hospital, surrounded by many strangers to them. So these children really need to be accommodated and well taken care of in terms of their distress. And their distress, by the way, can sometimes lead to hyperventilation or ingestion of a lot of gas that can cause their abdominal distension to complicate and amplify the issues of difficulty in breathing. So we need to support them. We need to deflate the stomach in that situation that I just mentioned. With regard to their emotional situation, again, yes, we need to support these children, not only them, but if the family, we should remember the family, and we should include the families during the management of children, provided the situation allows. Of course, for children who are in coma, who need immediate attention by the trauma care team for resuscitation, they have to keep the area empty from all others, especially the emotions will be very high in the emergency department when these children are rushed in. Well, having said that, it is unfortunate that worldwide there is a shortage of medical staff and surgeons, particularly in the low and middle income areas. And this also affects the nursing staff. If you just make a simple comparison between North America and some sub-Saharan African countries, you'll find that there are approximately over 150 nurses or midwives per 10,000 population, while in sub-Saharan Africa there are about 12 nurses. So less than 10% is the situation, and that adds to the burden and the load on the existing teams. And that's a flagging sign that people have to work on training more people in order to be able to deal with these situations. Because a limited number of trained people cannot be running the care for emergencies such as trauma 24/7. That's not the only problem, but worldwide, as mentioned earlier by Vinith, is that trauma is a neglected global problem, unfortunately. And children injuries have been neglected for a long time, and they are largely absent from the child survival initiatives. But now, fortunately, there are growing voices in advocacy for improving the care for pediatric trauma. As mentioned by my colleagues, time matters in the state of trauma. It needs timely and effective team approach to reduce the mortality and the disability that follows trauma. There is a trimodal distribution. It is known that, especially in severe road traffic accidents, motor vehicle accidents, about 50% or other serious injuries in different sites, including burns in close areas. So all severe polytrauma, in all those patients, 50% of them will die at the scene. So our focus should be on the remaining 50. 30% of them may survive for few hours, and those are the ones who will arrive in hospital, and those are the ones who deserve to be well taken care of in the initial assessment and management, to be given an opportunity for survival and for mitigation of complications. There is another group who may be easily survivable when they arrive to hospital. But as Shanti elegantly mentioned, that these patients need special attention. Otherwise, some of them may also progress to deterioration and even mortality. And those are the ones who do not receive proper initial management, who do not receive adequate resuscitation, or who will later on progress to developing infections and organ failure as a result. So these are the types of patients in whom we need to have more emphasis in their care And here, specifically for this group, there is a particularly, in fact, for all of them, but for this group, who should easily avoid, they have a very good chance of survival, but their condition may deteriorate due to mismanagement that in a large part may be related to the attitude of the treating team. And here the role of the nursing staff, and we appreciate that very much that they are on many occasions in charge of looking after the infection control around the place and putting everyone, including the administrators, the physicians, in line so as not to misbehave and lead to infections. Just simply following the existing protocols, which may be sometimes missed by some of the staff here and there. So again, this is something that needs to be praised in the role of the nursing staff in the care for the trauma. So since it is essential that patients have to be resuscitated instantly to avoid or reduce the incidence of mortality, you need good trauma services from pre-hospital up till arrival, and then in hospital, and then post, and then the rehabilitation care and post-discharge even, and schooling and all the requirements for those victims of trauma. But it's unfortunate that there is a great discrepancy between high-income countries and low and middle-income countries when it comes to these facilities. In fact, in some places, the way patients and children in particular are managed initially, it may amplify, may augment the condition and make it worse, actually. And in one of the studies, we found that in many African countries, the ambulance services are available for maybe about 11% of the population. So in current age, there are good trauma services recommended and applied as ongoing systems recommended by the WHO and applied in high-income countries that involves adequate communication with servers, and then the ambulance, and then the arrival, reception, and all these steps, all these are available on the website of the WHO, and you can follow them. Is it preventable? Well, what can I say after Antonio presented his nice talk? Yes, maybe more than 30% are avoidable, but it's a potential avoidable in most of the cases, or at least we can work to prevent the complications. One good example in Ghana, for instance, there is a Building and Road Research Institute that works, it's a governmental body, but that works closely in collaboration with the hospital staff in order to ensure that all the regulations are in place and applied to reduce the incidence of pediatric trauma. And as has been mentioned earlier, you can use the Hadoop matrix in the way of preventing trauma with regard to the agent, with regard to the construction and the environment. And also, as has been elegantly presented by Antonio, their work on the prevention, I'm not going to repeat that. Right. So, as I mentioned at ATLS, ABCDs, as have been mentioned, these are followed worldwide. But we also introduced, for children in particular, GICS, Trauma Care Initiative. And this is just to show that we also care, we should care for children with trauma, because if we don't do, you cannot rely only on politicians or physicians who are not in charge of children care to look after that side. It's our duty essentially. So we need people to care for trauma. So we need ownership, and that's the missing part. It's a no man's land. So we introduced the Global Initiative for Children's Surgery, Trauma Care. I think most of us know about the work of GICS And you are invited to visit the website to identify the different areas which are covered by the work of GICS. And the Trauma Working Group is one of the arms of GICS. And this is the mission of GICS. So when it comes to the trauma, we justified launching this initiative by the fact that it's a no man's land, it's an orphan, and the services are usually not organized or coordinated, and subspecialties management is fragmented. And these are particularly so in the low and middle income areas. So it is proposed to reduce the incidence of devastating effects of pediatric trauma by comprehensively addressing the various aspects of pediatric trauma. And this is to be done practically through encouraging development of local ownership. So it comes by local champions who can work with local authorities according to their local needs and locally available resources, and to utilize the networks such as the platforms of GICS for improving for the collaboration and improving their outcome. The GICS Trauma Care Initiative has been published in Children and it's available online. And it includes many facets, essentially to approach the trauma care comprehensively. It encompasses all the aspects from prevention up to capacity and confidence building. So going through the first aid, pre-hospital care, hospital and advanced care, intensive care, diagnostic facilities, OR, specialty services such as subspecialties, surgical services, rehabilitation, registry, which we are working on now on the branch of the PAPSA, the Pan-African Pediatric Surgical Association. And there are so many registries like those of the WHO, and many countries have got their own registries. And of course, to come in the end to the level of specialization and capacity and confidence building. And so these are the recommendations, and we advocate for these. There is a light at the end of the tunnel. The 2030 Agenda for Sustainable Development raises inequalities both within and between countries as deterrent to growth and development. And so there are many documents and activities going on, such as the establishment of the OREX documents and the NSOP documents. And you can find those on the resources of the GICS website. These are some of the activities of the GICS Trauma Working Group, essentially related to advocacy. And one of the arms is the prevention leaflets, which are also uploaded on the GICS website. Very simplified preventative instructions to families. And this is the website in which you can find most of the resources. So one of the other things that the trauma care group, the trauma working group has worked on is to run a course as part of the pre-hospital primary care. And this is a pediatric trauma care course. As I said earlier about trauma, it is unpredictable, but the good news, it is structured. It needs a structured approach. In fact, it needs prevention to start with. By anticipation and setting the mechanisms to prevent. But if it happens, then you need to have a systematic structured approach, such as the ATLS, ABCDs. But here in our course, we stated clearly, do not panic, just be systematic, and do not be carried away by emotions, just be systematic and deal with the problem. The course seeks to be a practical, direct, and concise guide to pediatric trauma management using local resources, and it is based on the Primary Trauma Care Foundation course. as mentioned earlier, profound shock is the main ultimate common pathway leading to death, in addition to the triad of death, the acidosis, the hypothermia, and the coagulopathy that follows the profound shock. And we just need to remind ourselves of that there are differences between children and adults, just to re-emphasize on these. And as mentioned earlier, we need to have guidelines. So in your emergency area or the wards or PICU, you better have these normograms or charts available for you for easy access to show you how to calculate the different requirements for children when it comes to tube sizes or when it comes to the volumes of blood and blood pressure. And you need all these charts of the normograms to be available for you. So in summary, there is a genuine need to draw attention of all stakeholders to the importance of proper focused training of all healthcare workers, particularly those dealing with children. There is a need for a great deal of political will, the need for allocation of funds to hospitals and all healthcare facilities that provide pediatric trauma services. But as Antonio mentioned, it is not enough to create protocols. Integration, in fact, it's important to be able to apply those protocols for the sake of children. And just to say here that is many a times in today's world, especially in high-income areas, that people are more distracted by filling forms, sitting at the computers, and doing little in the way of actually implementing the protocols or what they are writing to children, to the patients. One example, you come into an intensive care unit, neonatal intensive care unit, and find the baby drooling saliva, drowning in their saliva, and nobody is there to suck the saliva, to aspirate the stomach, the NG tube for a vomiting child, because some of the nurses may be too busy doing other clerical work or administrative work. So again, with the shortage of staff, we recommend that people should put more emphasis on taking care of their job of caring for the patient. And of course, not to omit the role of documentation, but that's not the priority for the good care for the patients. Integrated care is mandatory, not only for medical care, medical staff, nursing staff, but for all the community. And you can, the champions for the GICS Trauma Care Initiative can galvanize and include all those who should be concerned in the management of trauma, including the Ministry of Education, Ministry of Information, all the authorities, Ministry of Trade, the police department, the judicial system, the parliaments to issue regulations and legislations, and make sure that all these are implemented in order to come up with the good results that you need. So just to finalize here, this is the checklist which was mentioned earlier, just to remind ourselves of how we approach a very seriously injured child in an emergency department. The primary survey, care for the explicit bleeding, stop it by compression, by tourniquet, by packing, whichever way you have to stop that bleeding. If you are in an area where you have facilities, you can use the artery forceps and the surgical techniques. And the ABCDs and E's and F, including the family. Bilateral support cervical immobilization, or if you have a collar, that would be the best, until you clear the spinal injury. Open airway position, pulse oximetry placement, oxygen administration is mandatory. It's not enough to have a patent airway. Patent airway is for delivering oxygen. A patent airway without oxygen doesn't mean anything for the patient. So the patient needs the oxygen, and airway is just a vehicle for the delivery of the oxygen. Intubation and ventilation if required. Blood pressure check, but remember, it is the last indicator to change. Children do maintain their blood pressure to the last moment until they reach a level of irreversible shock when the blood pressure will start to drop, because they compensate by increasing the heart rate and increasing the peripheral resistance. But the blood pressure will drop in the end, and that may be too late, especially if the patient goes into bradycardia. You can use intravenous. If not accessible, go for intraosseous access. Give the intravenous fluid, bolus, whatever fluid available. Start with normal saline or with ringer lactate and get blood. And do not forget to sedate these children. They are in a lot of pain and agony that complicate their situation. Some of them may need inotropes. You need to care for their Glasgow Coma scale, their level of consciousness, and to avoid the issues that can lead to secondary brain injury, and to implement the brain trauma injury protocols. You have to remember to make sure that they are well warmed up to avoid the sequelae of hypothermia. And remember, the capillary refill time should be less than 2 seconds if you compress the finger nail bed for over the bed for 5 seconds, and then you release and see the capillary refill less than 2 seconds. Urine output should be between 1 to 2 mils per kg per hour. NG tube, provided that the patient does not have a fractured base of skull or suspicion of that. In that case, you may be able to put an orogastric tube if the condition would allow. And remember the splinting of the long bones. And as explained before, it's a very, very vast topic to be covered, but the basics, simple message is there. You need to be there, you need to be trained, you need to be prepared, you need to be safe. Be aware of your local epidemiology and try to get the data for that, and work and invest on the vaccine, which is the prevention. Educate your community. Children learn by role models and example, and involve governmental authorities. So you need a champion who can have the ability to move and find access to the decision makers in order to implement those steps. Prevention involves all members of the society, is not confined to the medical team and nursing team. So in conclusion, global health initiatives should collaborate by local champions, whether individual or as institution in whom resources can be involved, and leadership should set the example, as mentioned by Antonio. So in conclusion, GICS initiative encourages self-acquisition of a trauma care ownership by local champions, and this is what we advocate for and what we invite people to take over from such presentations. And we extend this to the community of the nursing staff. They can take the lead in that field. Some of the trained nurses are in many places are doing great job as coordinators for trauma, linking all the matrix of the teams dealing with the trauma, and that's a great job. So this aiming to take the and achieve the comprehensive service and develop it and be innovative, and by so doing, this often manages this neglected field, particularly in low and middle income countries. Thank you very much.
Thank you, Dr. Ali. Indeed, those were wonderful comments. It encompasses all the lectures shared by our resource persons, and everyone highlighted that children are not really small adults. And so all stakeholders have to put interventions and preventions that are designed specifically for pediatric need. So on this juncture, may I ask if we have questions from our participants? Do we have questions?
It looks like there's none at this time.
Yeah. Okay, so thank you to all our speakers and guests for being with us tonight. and sharing best practices and strategies in advancing nursing care in pediatric trauma. Since there are no questions, I would like to do the closing remarks. Thank you everyone again. As we conclude today's webinar on advancing nursing care in pediatric trauma, I want to extend our deepest gratitude to our incredible speakers, Dr. Dennis, Shanti, Dr. Philo, and Dr. Ali, for sharing their vital expertise, and to all of you for your active participation. The insights shared today remind us that specialized nursing care is the backbone of pediatric trauma recovery. By continuously refining our skills and implementing these advanced strategies, we directly improve the outcomes and lives of the vulnerable children in our care. Thank you for your dedication to excellence in pediatric nursing. Stay safe and have a wonderful rest of your day. This has been your host and moderator, Kay Avellano from the Philippines, signing off. Mabuhay po. Thank you so much.